So I'm going to have my patient seated, facing that way, and I'm going to ask him to remove his shirt so that I don't have to do so in the process. So just keep in mind, if this were a female, I would have to be draping, etc. for various things. So, may I have permission to palpate you for the duration of the slide?
Yes.
Good. Okay. So I'm going to start standing behind him. And what are the 3 areas that we're going to palpate standing behind the patient?
TMJ, atlas,
First rib. Okay. So I'm going to start with the atlas. So I'm going to go to the mastoid processes. I'm going to slide just inferior, so roll under, right, and then a slide anterior, and I'm going to turn my fingers and push from a lateral to medial direction, feeling for bony resistance, and I've located the transverse processes of the atlas. We want to see your fingers like this. We want to see your arms out like this. If you're here, there's no way you can palpate that atlas through that soft tissue. So you've got to push lateral to medial, feeling for that bony resistance.
And we're avoiding the styloid.
And we are avoiding the styloid process. That's a biggie. You got to say that, right? Okay, next we're going to go to the temporomandibular joint. So our landmark starting point is going to be the tragus of the ear. I'm going to go just anterior to the tragus. There will be a little horizontal gap there. I'm going to have the patient open and close his mouth. And when he does so, the condyle of the jaw moves away, and it should move symmetrically. There shouldn't be any popping or clicking, and then I'm going to ask the patient if he has any pain.
No.
No? Okay, so good.
I can hardly hear you.
Oh. Do you have any pain?
You're all right.
Okay, so now we're going to move down to the ribs, right? People mess this up all the time, and it's the easiest thing. 2 fingers, sip and if, lateral margin of the neck, stop. Right there underneath my sip is the first rib on each side, but I've got to get the trap out of the way, right? So I'm going to move my fingers posterior to the clavicle, anterior to the trapezius. So I'm just going to wrap the traps and kind of pull them back, and then I'm going to go where they just were, and I'm going to palpate in a superior to inferior, lateral to medial direction, feeling for bony resistance, and I've located the right first rib. If it were the left, it would look like this. But let us know you found bony resistance, right? Because if you haven't, then you're not on the first rib. Don't forget your verbiage. So those are 3 things that we palpate from this direction. Now we're going to move on to the cervical spine. And I want somebody to give me something in the upper cervical and somebody to give me something in the lower cervical as far as a articular process.
C3 articular process on the right.
Wow, see, it's just like the test, right? So what I heard of that was the right. Right, I really heard the rest, but I'm going to pretend like I'm nervous, and all I heard was right. So I want him to get into position to where I'm on his right side. So he's going to come sit down at the end of the bench facing that way. No, doctor, what did you say?
C3.
Okay.
On
So
the right.
to find the C3, I'm going to start at my landmark of C2 spinous process. So I'm going to stabilize the patient's head and neck, get him relaxed so that the muscles are relaxed. I'm going to locate the C2 spinous process. I'm going to use the finger slide technique to move down to C3, which is right below C2. I'm not sure I'm on it, so I'm going to flex and extend. Oh, there's C3 spinous process. Now I'm going to move out with my sip and thumb, 3/4 of an inch to an inch. I'm going to pull the soft tissue back. I'm now going to move forward from a P to A direction, palpating for the right articular process of C3, which is under my thumb. Somebody else give me a lower cervical articular process to find.
T8.
Who?
Oh, you said cervical? Sorry. I'm going to be quiet today.
C5. C5. C5 on the left. Okay. So I have to get on the patient's left side, don't I? So for ease of you being able to see, I'm going to be creative. I'm going to have him face that way. Does that place me on his left side? I'm good to go. C5, what's my starting landmark for C5? This is a hint. We've got to find the vertebral prominence, right? So I'm going to put my sip and if on the 2 most prominent vertebrae. I'm going to have my patient completely relax his head into my hand to relax the musculature. I'm going to place him back into full extension, feeling for the spinuses and feeling to see if one of them translates away from my contact point. And the one underneath my index finger does, and so in this situation that makes that C6, makes his VP C7. if it didn't translate, that would mean that this one is C7 and this one is T1. So those are the two circumstances that exist. So I just gave you I gave you everything for the VP, right? Didn't have to do that because I'm going to C5, but I just did it. So I've located C7, C6, so I'm going to take my finger slide technique up. I'm going to bend his head forward, finding the C5 spinous process. Take my sif and if and just move the soft tissue out of the way. I'm going to push in a P to A direction, 3/4 of an inch to an inch out lateral, and my thumb should be on the left articular process of C5. So y'all see what I did with the VP. I didn't have to go to all of that. I could have just found C6 and gone up from there. Okay? All right, so let's go on to the thoracic spine. Somebody give me something, transverse process that you want me to find and verify. T8.
Using a landmark.
Oh, I can't use a shortcut?
T9.
Huh? No.
If you're given one, we will tell you using a shortcut or using a landmark, so you've got to listen to that.
Could you demonstrate both?
Yeah.
Yeah.
Let's have our patient lie face down.
Thank you.
All right. So,
It's everywhere.
patient position is lying prone. I'm going to get in my scissor stance, right? I'm finding what one? T8 on the
Left side.
good. T8 transverse process on the left side. Find and verify, right? Okay. So I've just confirmed that his vertebral prominence was C7. So since I just confirmed that, I can use that, right? If I didn't, I'd have to bring him up on his elbows. So I know that his VP is C7. So with my inferior hand, I'm going to do my finger slide technique down to T1, T2, 3, 4, 5, 6, 7, 8. T8 spinous process. I've arrived from this T8 spinous process. I'm going to move up 2 interspinous spaces, out lateral a full inch, taking out soft tissue slack, leaning over the patient with my episternal notch, backing up my thumb with the rest of my fingers, straightening my arm, leaning in and pushing pressure on the transverse process, feeling for the spinous process to wag. I'm waiting in case somebody wants to verify.
We believe you.
Okay, good. Now, finding the same thing using a shortcut, I'm going to come to the inferior angle of the scapula. I'm going to draw a line across to bisect those points. That should put me at the T6 spinous process. I'm going to do the finger slide down to T7, T8. I'm going to go up 2 interspinous spaces. And make sure that there's clarity with your hands and fingers here. I see a lot of this and going up and out, and it's real unclear as to what you're doing. So spinous process, move 2 interspinous spaces out a full inch, take out the tissue slack, right? And what that means is I'm pulling the tissue taut so that this isn't happening, right? Leaning in with the body weight, pushing down with, and I'm leaning with my whole body to make that transverse process wag. I'm not doing this, and I'm not doing this. And that's definitely a 2, which totals out to be a 4-point deduction if you're not given a good wag there. Okay?
So if he was sitting up, that inferior angle of the scapula would be at what? T7?
T7.
7 up.
Yeah, that's the short.
And laying down is
Really, the
T6.
spine of the scapula isn't a common shortcut that doctors use. We use the inferior angle of the scapula all the time. I trace the ribs in all the time, but that's not one that we've taught y'all. Iliac crest across to L4, right? So somebody give me a lumbar.
Could you explain the
Levels?
intervals on the 2 interspinous spaces and just what is it in the thoracics again?
The easiest way to remember that, y'all, is to think anatomically, right? If you think the spinous processes are more vertical from 5 to 8, so that's why we have to go up 2, right? The other ones are just 1 spinous space.
Because the curvature.
So you just
One
have
spinous
an understanding. Huh?
One spinous
One
process.
spinous process, sorry. Yeah.
So from T1 to 4, it's 1 spinous process. From T5 to 8, it's 2 interspinous spaces, and from T6 to T12, it's 1 interspinous, or 1 interspinous process.
You do it so well.
One spinous process.
1 spinous process.
You got it.
Somebody
There
give
you
her a
go.
lumbar.
Somebody give me a lumbar.
On the left, so we can look at her
We
good
just
side.
wanted to watch her dance.
Just kidding. I'm just kidding. I didn't say that out loud.
Okay, somebody give me a lumbar.
So we can see what you're doing.
L2 shortcut or landmark? L2 shortcut. I'm going
L2
to locate the
shortcut.
L4 spinous process by finding the iliac crest, bisecting a line straight across to the L4 spinous process. What level? L2. L2. So from L4, I'm going to go up to L2, L3, mammillary process? Yes. Right, because that's what we did. So we're at I'm at L2, spinous process. So from here, I'm going to be locating the left mammillary process. So I'm going to go up one interspinous space, which is really teeny tiny, right? There's not very much space between them. Out half an inch to 3/4 of an inch, and I should be over the mammillary process of L2 on the left.
Perfect.
Can you do that with a landmark also?
Would you like for me to do it with a landmark?
Please.
Okay. So what do you want me to find with a landmark?
The L2.
L2 left mammillary process using landmark. The closest landmark in this particular situation is going to be the lumbosacral junction. So I'm going to go through the steps to find the lumbosacral junction. I'm going to follow the ribs down to the inferior angle. I'm going to turn my hands in knife edge. I'm going to knife edge into the soft tissue, drop down to the iliac crest. From the iliac crest, I'm going to pivot. We call that a windshield wiper down to the inferior notches of the PSIS. Both thumbs on the inferior notches of PSIS. My superior hand, index finger rotates medially, bisecting the point where my thumbs, the line where my thumbs have drawn. That's the S2 tubercle. I am not going to raise my finger off of the S2 tubercle, but I am going to turn it cephalad, and I'm going to slide cephalad until I fall off the sacrum into a soft tissue space. Feels like I've found it there, but I'm going to verify with my inferior hand by coming onto the sacrum, feeling bony resistance, soft tissue. So I've just verified that I indeed had found the lumbosacral junction with my superior hand. With my superior hand maintaining my spot of the lumbosacral junction, I'm going to take my inferior hand just above that, and I should find the L5 spinous process. I'm going to do the finger slide method up to L4, L3, L2. I'm going to go up one interspinous space, out lateral half an inch to 3/4 of an inch, and I should be on the left mammillary process of L2. Now, here's what I see that goes wrong. Okay? Everybody does this, we're good, we get here, we get to S2, and we go shopping. And if you tell me that's the lumbosacral junction, I'm not going to believe you because I can see the inferior angle of the ribs coming in. Okay? It's just superior to the sacrum right there. So the minute people raise their finger up off of S2 and go searching, you're lost. Okay? So just know that it's right there. Okay? And even if you're not exactly on it, it's going to be more believable than if you're up way high. Right? So if you're counting, if you say that that's a lumbosacral junction, you go up to L2, guess where you're going to be? I see it all the time. So don't make that mistake. The mistake starts with miscalculating where the lumbosacral junction is. Okay? It's soft tissue. You can feel it. That's bone. That's soft tissue. Okay. What else? We have structures in the pelvis that we need to find, right? Greater trochanter. What's that? Sacrohiatus. Same method utilized here. The biggest difference is when I get here to the S2 tubercle, I'm going to turn caudad, rotate, still staying on S2, sliding inferiorly till I get to the flat part of the sacrum, and that's the sacrohiatus. Skin on skin. Remember skin on skin when you need to. Make sure that when you're doing lumbosacral junction and finding these transverse processes on females that the gown is open and you're skin on skin. Okay? It's a 2-point deduction if you're not skin on skin. Okay, next.
What question on that? What do you actually use that point for adjusting for?
On the sacrum? The sacrum, it goes through a nutation motion, and sometimes the base gets stuck anterior or posterior, sometimes the apex, and so you have to be able to find those structures on the sacrum so that you know where to set up to adjust. I saw a gentleman on Wednesdays. I have a private practice, and I saw a gentleman that's suffering with low back issues, has a disc herniation, and his sacral base keeps rocking forward. And so I actually do a particular test for it, and then I do a drop technique on it where I'm contacting the apex and torquing the apex down to bring the base up. So you have a lot of contacts in the pelvis, a lot, particularly with low back situations. The greater trochanter of the femur, you start out cephalad, right? It's kind of a tough one to write. You start out cephalad, but then you're going to turn. You're going to place the heel of your hand on the patient's lateral superior iliac crest. Drop the fingers down till you feel bony resistance. You're going to grab the lower extremity. You're going to bend the knee, and you're going to rotate the femur internally, externally, feeling for the greater trochanter to move underneath your fingertips. Okay, if they have a really long leg, it's okay to switch arms, switch hands, as long as you keep your point on the greater trochanter. Next is the ischial tuberosity, which is the most inferior aspect of the pelvis, and you definitely will be contacting that and adjusting that. So you're going to use your superior hand, tuck the thumb, use a couple of fingers. You're going to draw an imaginary line at the inferior gluteal fold, mid-thigh. You're going to move in a superior anterior medial direction. I'm about to touch your ischial tuberosity. And right there it is. Okay.
That was perfect.
Yeah, right?
You got that on video?
Okay, so now we have anterior pelvis. So I'm going to have my patient turn face up. So the thing we need to find on the anterior pelvis is the pubic tubercle, right? And we know the pubic tubercle, there's an important ligament that goes from the pubic tubercle to the ASIS, right? So we'll identify the ASIS, just find the iliac crest, follow it around, has very prominent ASISs. The inguinal ligament runs down and attaches to the pubic tubercle. I'm on his right side. People get mixed up right and left on pubic tubercle, right? It's his right. So I'm going to ask him to move his melanatomy to the left while we all turn around. He's going to let me know that he's done that.
Thanks. Get the video off of me. That's
Yeah.
okay. I'm ready.
Okay. So what I'm going to do is have him place his hand on his umbilicus, drop his fingers down till he feels bony resistance. It's important people forget to say that, and so the person doesn't know what they're looking for, right? Do you feel a bone?
Mm-hmm.
Okay, I'm going to replace your fingers with mine, usually 2 fingers, thumb tuck, right like so. I'm going to slide towards me, never across, towards me, 1/2 inch to 3/4 of an inch, and right there's a pubic tubercle. If I needed to verify that, I could by tracing the inguinal ligament from the ASIS down to the pubic tubercle. Okay. Since he's lying in this position, I'm going to go ahead and go to the lower extremity, right? So we're going to start with the knee bent somewhere between 70 and 90 degrees. The key is we want to be able to get our fingers in the popliteal fossa. You want to place your thumbs in this soft tissue depression on either side of the ligament, patellar ligament, right? Where we are when we're there is we're in the joint space. Superior to that is the femur. Inferior to that is the tibial plateau. So from the medial side, medial tibial plateau, we're just going to identify that by sliding outward, right? Okay. You go inferior to that, there's a tubercle. And what attaches there?
Pes anterior.
Pes anterior, right? So sartorius, there's three muscle groups.
Sartorius.
So important area, right? We come back up to that soft tissue depression. Slide medial and inferior, and there's the tibial tuberosity, right? What happens at the tibial tuberosity in young athletes? Osgood slaughters, right? Yeah, they're working out the glute or the quadriceps, and the quadriceps get strong, and so this hasn't fused yet. This attachment of the ligament to the tuberosity, and so it starts to pull it away. And it's a really painful condition. So. You need to be able to recognize that in your young athletes. Okay, still on the medial side, I'm going to slide superiorly to the femoral condyle, which I can feel here. If I go more medially, there's the medial epicondyle, right? And if I go further medial, there should be a tubercle there, right? And what attaches there?
Adductor magnus.
Right? So your big adductor muscle group attaches there. Okay, now I'm going to go to the lateral side of the knee, so I'm going to use his lateral leg so that y'all can see. So I'll just bend this one. He's been good. He's letting the doctor call the shots. So again, same starting position, fingers wrapped around, thumbs in the soft tissue depression. Here's the lateral tibial plateau, right? Inferior to that is the head of the fibula, right there. And I could verify that if I wanted to by dorsiflexion, plantar flexion. You can see his moving, right? Let me see yours moving. Okay. Back up to the soft tissue depression. Go superior to that, and that's the lateral femoral condyle, and our little bit out further outward is the lateral epicondyle. Back to that soft tissue depression, I can run cephalad. In doing so, I will find the medial and lateral, I don't know what you all call them, it's where the patellar groove is formed, right? The patella glides in there, and you can actually feel it a little bit better with the legs straightened out.
Isn't the
Okay.
intercondylar groove? I think it's intercondylar groove.
Intercondylar groove, yeah. It's also called patellar groove. Dr. Giggle and I met on Monday, and we're trying to
I think he
sync
called
up
it
the-
intercondyle.
Yeah, 'cause there's a
Intercondylar
medial and a
groove,
lateral
yeah.
condyle, so that's where the patella glides,
say that
right?
word.
And so it's an important structure because the patella can
Intercondylar.
subluxate, right? And when it does, it usually goes medial because the lateral groove is deeper. It's more prominent. Okay, so that's everything in the knee, I believe. And so now we're going to move on down to the ankle and foot. So to palpate the lateral aspect of the foot, I'm going to hold the medial side, holding the calcaneus, right, that gives me ease of palpation. I'm going to identify the lateral malleolus. Just inferior to the lateral malleolus is the talus. Okay, just inferior to that is the, no, that's on the other side.
I was just mumbling. Go ahead.
Yeah. So there's the talus. If we come across the top of the foot, which is the dome of the talus, right?
Yeah.
That's not how we do the lateral side. We start on the lateral side. We start at the base of the fifth metatarsal.
Fifth metatarsal.
I always do medial first, and I'm doing lateral. I'm like, this is not running smoothly. So lateral aspect of the foot, we start by sliding along the lateral aspect of the fifth metatarsal until we get to the tuberosity, right? Also called the styloid process at the base of the fifth metatarsal. As we go into that divot, we will find a cuboid bone, which is a very large bone, takes up this whole space. Beyond the cuboid, which would be continuing on, we'll find the calcaneus. Go around the back of the calcaneus, and there's the dome of the calcaneus. And there's also a peroneal tubercle that is palpable where the peroneus muscle group attaches, right? From here, we have the cuboid. So let's go back to the medial side of the foot. So if I'm palpating the medial side of the foot, I'm going to hold the lateral side of the foot. I'm going to identify the medial malleolus. Just inferior to the medial malleolus is the
Talus.
Talus is going to be about a finger's breadth down. So it's where the spring ligament attaches, and that's what cued me that I was on the wrong side of the foot because the spring ligament supports the arch. So there's the sustentaculum tali. The talus is right there. Okay. So from identifying the talus is immediately below the medial malleolus, come across the top of the foot to the dome of the talus. Okay. Just inferior to the dome of the talus is what structure? Navicular, right? So the navicular is literally the keystone of the arch. So if I go up into the arch and move just down from the talus, this whole structure right here is the navicular. Very, very large bone, okay? And then it articulates directly, if I go towards the lateral aspect of the foot, with cuneiforms 1, 2, and 3. Now, to palpate the rest of the bones, what we're going to do is take both hands, identify the medial and lateral malleolus, noting that the lateral one definitely extends further, right? And then I can come in, I can actually palpate these bones. So anytime you're palpating in the carpals or tarsals in the foot, it's best to hold the bone proximal and move the bone distal. So I can actually hold the talus and move the navicular, right? Come across, move the cuneiforms, right? And then the cuboid actually articulates with what two bones, what two?
4 and 5.
4 and 5.
4 and 5.
Yeah. So then we can come down, stabilize this whole long structure here are the metatarsals. So we can hold one metatarsal and move the phalange in relationship to the metatarsal and then challenge each joint. So just remember hold proximal, move distal. So I'm checking the metatarsal phalangeal joints of each bone. Okay. So essentially in the ankle we identify the medial aspect, the lateral aspect, and then we come and we palpate the actual bones in the foot. They're difficult to feel that you actually are on one. The best way to tell is to start moving it around, kind of like we do in the wrist and hip.
So how would you ask us a question for that? You say find the navicular, find the...
We're probably going to have you find the cuboid, find the navicular, find the talus, identify perhaps the calcaneus and the, yeah, could be any of those structures.
But if it's just one, I mean, there's not a step or like a process
No.
to go through to get
You
to.
just have to know where to start.
So
right?
the verbiage isn't going to be as specific
No.
as it was.
No, I'm looking for you to find a good starting point, a reference point, and give me kind of just like what we talked about in the
A
sheet, how
roadmap.
you got from there to there. All right? So if you're looking for the sustentaculum, I want you to identify the medial malleolus. I want you to go a finger's breadth below that, and then palpate the protuberance, which is the sustentaculum. Pardon?
Body
Body
resistance.
Yeah.
Oh my.
Yeah. Okay, that's lower extremity. Let's move up to the upper extremity. We're out of juice. Pardon me?
What'd you say?
Out of juice.
Stomach work out?
Yes.
See a little bit.
Definitely.
Okay, so we're palpating the upper extremity, so we're going to start with the SC joint, the sternoclavicular joint, right? To palpate the right side, I'm going to reach around with my left. If we're looking for the left, I'm going to reach around with my right. Okay, everybody with me on that? So I'm going to come around and I'm going to identify his xiphoid, his episternal notch, right?
That thing.
Also called suprasternal, right? So I'm going to go just to the lateral aspect of that, put one finger on the sternum, one finger on the clavicle at its proximal end. I'm going to take his elbow, and he's going to be passively relaxed, and I'm just going to move the arm up and down. And when I do that, I can feel the clavicle move in relationship to the sternum, and I know that I've identified the sternoclavicular joint. Okay? From there, I'm going to trace the clavicle from the proximal 2/3 to the distal 1/3. And from there, what's going to happen is I'm going to run into where the clavicle terminates into the acromioclavicular joint. So what I'm going to do from there is I'm going to place one finger, and it just makes sense to use your sif and put your if on the acromion, which is this flat structure here. And then I'm going to take his arm passively, flex, and when you flex, you'll feel the acromion move in relationship to the distal clavicle. Okay? Using the distal clavicle as a reference point, I'm going to slide obliquely lateral, and then, sorry, I'm using this hand because I'm going to move this one. If you externally rotate, you'll feel the Corco process easier. So I'm going to slide lateral, obliquely lateral, and then I'm going to push in a anterior to posterior direction, feeling for, then there it is, Corco process of the scapula. Okay. From here, we're going to go back to the acromion process. We're going to slide off the lateral aspect of it, feeling for the greater tubercle, right? And sometimes if you externally rotate, you can feel that easier. So there's a greater tubercle, intratubercular groove, and then the lesser tubercle right there. What important structure runs through the intratubercular groove?
Long head of the biceps brachii.
And so sometimes what you can do is have them resist, hold it, resist flexion, and you can feel the biceps contracting in that groove.
Nice.
Transverse humeral retinaculum.
There you go. Okay. So you see here, it kind of, you just have to work with it to get the flow, but once you get here, you know you've got to move these, and so you go from here to here, right?
Let me spin around.
Yeah, so we're gonna do elbow, so,
Oh, you want to do spine? Let me shut up. You do it.
yeah, I mean, you know, if you're gonna, I can tell you, we're not gonna have you find a spinous process with the patient seated, but we may have you identify the vertebral border of the scapula, the lateral border, and the inferior border. And then the superior border, if you'll notice in the notes, after looking at the skeleton, I changed it. I said you go medial from the vertebral border. You actually go a little bit lateral and superior to find it. So if you bring the arm back behind the body, it's going to make the scapula a lot more prominent, so you can identify all the boundaries of it, right? So here's the superior angle, medial, vertebral border, inferior angle, and then the lateral margin of the scapula. Okay.
Are those notes current up on Blackboard right now?
I know the lower extremity is. I think the upper extremity is. I'll definitely make sure before next week. So go ahead and turn towards me, just like that. Yeah, we're going to do palpation of the elbow. So you're facing the patient. The arm is bent. You're going to take your thumb and index finger, or it doesn't matter which finger you use. Just identify the medial and lateral epicondyles, right? From the lateral epicondyle, I'm going to slide slightly distal, and then I should be over the head of the radius, and I'm going to move the forearm into pronation and supination, feeling for the radial head to rotate underneath my thumb. Then we're going to move down to the wrist and hand. I'm going to identify the medial, this is the distal ends of the radius and ulna, so the radial and ulnar styloid processes. I'm going to go towards the ulnar side and palpate the Lister's tubercle on the radius, which will line up with the first carpal, which is the lunates. And so when I leave the Lister's tubercle, I'm crossing over the joint. You can feel it by bending and extending the wrist. And so you know that you've crossed over, and the first bone that you come to should be, which one? Lunate, right? So if we go towards the thumb side, our next bone should be the navicular, right?
Or scaphoid, yeah.
Scaphoid.
He calls it scaphoid in the hand. He said it has another word. Is yeah.
But it's known, the scaphoid is also known as the navicular.
Yeah.
But in the foot, it's always the navicular.
Right.
Yeah.
So then we come back to the lunate, and we go
fine.
towards the ulnar side, and our first bone that we come to should be the triquetrum. As we pinch, the front side of it is the pisiform. So once you've found triquetrum, just reach on the front side and pinch and find the pisiform. We go back to the lunate in a line following the sif. We go one carpal distal, and we should be on the capitate, right? From the capitate, moving towards the thumb side, we should find the trapezoid, and then the trapezium next to the thumb. Come back to the capitate, and going towards the ulnar side, we should find the hamate. Pinch on the front side, and you should find the hook of the hamate right there. So if you have any doubt on these carpals, hold proximal and move distal, right? You can hold the proximal row and move them distally. So it's kind of a shuffling motion that you create. Then we have the metacarpals, right? And then we have the metacarpal phalangeals. And so again, you're going to stabilize proximal, palpate distal, all the way down to the DIP and all of them. Thumb only has two, right?
Yep.
There's the MCP and then the interphalangeal joint. Ta-da!
Thank you.